Well, hi, everybody, and welcome. My name is Neil Seidman, and I'm the co-chair of the Public Education Committee for ADAA. That's the Anxiety and Depression Association of America. And we're really happy to present this webinar, Treatment for Anxious and Depressed Kids and Teens, Science and Treatment Options. And our presenter is Dr. Daniel Pine. Now we're going to be recording the webinar, so you'll have a chance to see it again on the ADAA website. Now during the webinar, you can type in your questions. If you look on the right side of your screen, you should see a Q&A panel. And there's a little field at the bottom of that panel. And when you click in it, you can type in your question. Then hit either your enter key or click the icon. So you can type in questions during the presentation. We're going to have a Q&A period at the end, and we'll get to as many questions as we can. Now before we start, I'd like to say just a little about ADAA, the Anxiety and Depression Association of America. ADAA was started back in 1979. And today it's the leading nonprofit organization in the field of anxiety disorders and depression. And our mission is to improve diagnosis and promote the prevention, treatment, and cure of anxiety, depression, and stress-related disorders through education, like this webinar, through practice and research. We work to end stigma and get the word out that these conditions are real, serious, and treatable. So I really want to invite you to spend some time on the ADAA website. That's adaa.org. It's a fabulous resource. And you can support ADAA by making a charitable contribution on the website. Okay, so I'm really privileged to introduce our presenter, Dr. Daniel Pine. With the National Institute of Mental Health, Dr. Pine heads the section on development and affective neuroscience in the intramural research program. Dr. Pine specializes in research on pediatric mental disorders as reflected in over 350 peer-reviewed papers. With the FDA, Dr. Pine served as the chair of the Psychopharmacological Drug Advisory Committee. He also served as chair of the Child and Adolescent Disorders Work Group for the DSM-5 task force, and president of the Society of Biological Psychiatry. Dr. Pine is a member of the Institute of Medicine of the National Academy, which is among the highest honors for a physician, and he's received numerous other awards. So let me turn it over now to Dr. Pine.
Thanks a bunch, Neil. So it really is a pleasure to be able to give this webinar. And the plan for the talk this evening is that I'm going to spend a little over a half an hour going over material that I'll provide the outline for in a second. And then we're going to open it up for questions that you should be submitting by typing them into Neil, and then I'll explain what the question is and give the answer to it. And you should feel free to ask questions either about the material that I'm going over, which is going to mostly focus on two varieties of mental health problems in kids. That's problems with anxiety and problems with depression, as well as really any mental health problem in kids that you might encounter or that you might like to have the answers to. All right, so do you have the slides, Neil?
Yeah, can you go ahead and
Can Can
you
you
should be able to advance the slide if you go down to the bottom left corner. You'll see the little arrows.
There we go. Okay.
There we go. We're off and running.
All right. Let me just get a full screen. I don't really have a... All right. All right. So as I mentioned, I'm really going to be covering a couple of topics. Most of the talk is going to deal with clinical issues because I found that those are the kinds of issues that mental health consumers usually want to hear the most details about. And we're going to talk really about 4 different things. First, we're going to talk about the variety of mental health problems that present in kids, both anxiety problems as well as depression problems. And then we're going to fairly quickly move to talking about what happens over time in terms of when kids grow up and have these problems, whether they go away or whether they persist. And we're going to talk about that from the standpoint of longitudinal studies. Next, we'll talk about family studies, how problems aggregate within families, both related to depression and related to anxiety. And then third, we'll spend most of the time talking about the available treatments for anxiety and depression. And we will be contrasting some of the differences between treating problems with anxiety and treating problems with depression. And then we're also going to talk about what we call efficacy, or how well treatments work, as well as what we call adverse effects, or some of the problems with treatments. We're going to end for about 5 or 10 minutes talking really about the future. And this will come out of research on neuroscience. And I'm really going to talk about 2 things. I'm going to talk about the circuitry that's involved in fear among animals, but then I'm also going to talk about how we use that research in animals to try to answer questions about diagnosis, which we're not that good at yet in terms of using neuroscience to understand diagnosis, but then also design novel treatments where we're already having a little more success. All right, so the first thing to go over is the nature of problems that present in kids in terms of anxiety and depression, and then what happens to them over time. So the first problem that we're going to talk about is something called major depression. And a lot of mental disorders are described using words that have both medical meaning. So in this instance, major depression is a very specific entity that has a precise medical meaning, as well as common meanings. So depression is a term that we use very frequently to talk about feelings that we have as part of regular life. And so particularly in kids, because there are a lot of instances where kids manifest depression as part of their normal everyday lives, it's very important to differentiate between normal or typical kinds of depression and abnormal depression, and we use the term major depression to refer to the abnormal kind of depression. So major depression is extremely common. Somewhere between 5 and 20% of adolescents at some time will have a problem with major depression. And we use 2 main what we call criteria or indicators to tell the difference between normal depression and abnormal depression. So the first is the nature of the depressed mood that a child has. When a child has a depressed mood that is part of abnormal depression or major depression, that perturbation is both persistent, meaning that it lasts all day, and pervasive, meaning that it goes on for many, many days in a row in all different settings that child might go. Specifically, this perturbation in mood must be present every single day, all day, for 2 weeks or longer. And that's the first rule that we use to think that depression that a child is manifesting might be a sign of something problematic. There are a number of other symptoms that go with this, symptoms like disruptions in concentrations, problems in sleep, thoughts about suicide. And the second thing that we use to indicate that signs of depression are a problem is that those signs are associated with what we call impairment, which is interference in a child's ability to do things that other children who don't have depression can do. So both the degree of depressed mood and the way in which it impacts functioning is how we differentiate normal from abnormal signs of depression. When major depression is present, it seriously impacts a child's ability to function by interrupting their ability to attend school, disrupting their friendships and their family life. And there is a very particular relationship between age, gender, and major depression. So major depression is very rare before puberty. Far fewer than 5% of kids will have major depression before puberty, which is typically around 10 or 11 for a girl and 12 or 13 for a boy. And the rates of depression before puberty are equal in boys and girls. After puberty, so as kids approach adolescence, and particularly around age 13 or 14, rates of depression increase dramatically, and they increase particularly in girls, more so in boys. We're very concerned when we see a child with major depression because relative to the anxiety disorders, which I'll talk about next, there is a greater tendency for depression to be recurrent or persistent, and we would really like to be able to prevent depression rather than trying to treat it. And when we talk about anxiety disorders next, one of the hopes is that by better treating anxiety, we might actually have an impact on depression. And the last thing to say about the presentation of depression is that there is a fair amount of controversy about the difference between depression, which I've just described, and another variety of mood disorder called bipolar disorder. And the controversy relates to the fact that bipolar disorder is generally regarded to be a rare condition, but there had been some thought that the diagnosis might be more common than had previously been thought prior to around the turn of this century. The thinking now is that that's not really correct, that the disorder still is quite rare, but this is one of the areas where listeners might have more questions about how to differentiate bipolar disorder from depression and how some of the things about bipolar disorder are different relative to the information that I'm going to give right now about depression and also anxiety disorders. So anxiety disorders are different from major depression in a few ways. One way is that there are many different types of anxiety disorders, and we typically group these into three broad categories. So OCD, or obsessive compulsive disorder, is the classic condition in one of these categories, and this refers to a pattern of recurrent worries or obsessions about particularly anxiety-provoking circumstances. So, for example, a frequent obsession is a concern about checking things like homework or to make sure that a child locked the door when they left the house, or about cleanliness or sins. And these obsessions are also frequently associated with compulsions, which are behaviors that are designed to neutralize those worries. So a child who's obsessed about locking the door will frequently check. A child who's obsessed about cleanliness will frequently wash their hands. Post-traumatic stress disorder is a second type of anxiety, and this is associated with anxiety that follows after a traumatic, life-threatening event. And then the third group of anxiety disorders include things like phobias, something called GAD, which stands for Generalized Anxiety Disorder, Separation Anxiety Disorder, and a range of other conditions. And we typically think of anxiety disorders as falling into these three groups because things like biology and longitudinal outcome and familial aggregation of these disorders suggest that they differ from one another along these three categories. Anxiety is also different from depression in terms of its prevalence. So it's more common than major depression, and it is often more difficult to tell the difference between normal and abnormal anxiety relative to normal and abnormal depression. And that's because anxiety is both much more common, but then also grades relatively gradually from normal levels of anxiety into levels of anxiety that could be indicative of a disorder. And here the main criteria we use is something called the impairment criterion. And the idea behind impairment is that children who avoid doing things that prevent them from completing activities that other children can do are said to suffer from an anxiety disorder. So many children are worried about going away from home, for example, when they're young. It's the child whose worries prevent them from actually doing things that we would think of as having an anxiety disorder. Similarly, many kids are nervous when they meet new children or when they attend parties. It's a very common symptom. It's the child who could not make it to the party that we would think of as suffering from an anxiety disorder. There is also a different relationship between age and gender in the anxiety disorders and depression. Remember, I said that depression was quite rare before puberty. That is not the case with anxiety disorders. Anxiety disorders are common both before and after puberty. And then remember I said that the relationship with gender really comes out after puberty, where girls are more likely to have depression than boys. Again, that's not what we see with anxiety. Anxiety is already more common in girls than it is with boys, even before puberty. And that makes us think that maybe anxiety is an early indicator of the risk for depression. And when we follow kids with anxiety disorders over time, we find that to be the case. It is a risk factor for depression. Well, what else do these longitudinal data show? So I'm now going to show you data from one study that I will walk you through, and if you look in the lower right-hand corner of this study, you can see that this study is in 679 children who were followed longitudinally all the way through adolescence into adulthood. And this study shows you the relationship between having an anxiety disorder during childhood and having either a mood or an anxiety disorder in adulthood. So the way you read this table is you look at the rows to see whether children are divided into a yes group who had an anxiety disorder at some point during adolescence, or a no group who didn't. And then you also look at the columns, which show you whether these individuals had a mood or anxiety disorder in adulthood. So that would be in the column on the right under yes, or did not have a disorder in adulthood under the no column. And there are three main findings to take away from this study. The first finding is if you look at the far right, you can see that anxiety disorders are extremely common. 253 out of the 679 kids in this study, or about a third, had an impairing anxiety disorder at some time during adolescence. Number two, the disorders, the anxiety disorders, usually go away. So 191 out of 253 of these kids who had an anxiety disorder were fine when we saw them as an adults. And that's very different for anxiety disorders than it is for depression. All right, so anxiety is much more likely to remit or go away than depression. And when many people see this finding, they tend to think that anxiety disorders are a relatively benign condition. But that would be an incorrect way to read these data based on one final finding that you can see here. And this shows you that there are 98 of these adults who were affected with a mood or anxiety disorder. Of those 98, 62 of them had their problems start when they were kids. So what this tells us is that while anxiety is very common, about a third of kids will have it, and it usually goes away, about 2/3 of the time, the problem won't be present in adulthood. For that minority of kids, the 62 kids here, or about 10% of the sample, who have an anxiety disorder in childhood that persists, they will grow up to account for the majority of adults with a problem. So that's why we really care about childhood mental disorders, not just because they affect children, but they're often the initial signs of chronic problems that we see later in adulthood. All right, let's just say a word about familial genetic associations. And here we're just going to start by talking about what we call familial aggregation, or how disorders run in families. And the first thing to note is that there is a strong relationship among anxiety and depression in parents and children. Parents with anxiety and parents with depression are both likely to have children who also have problems with anxiety. So this tells us that anxiety and depression run in families together. Moreover, when we look at very young children, we see that there are certain kind of behaviors or certain temperaments that we can also detect in children that are a sign of this risk for anxiety and this risk for depression. Now, both findings here relate to how problems aggregate. This says nothing about genetics or the environment. When things run in families, it can be due to genetics, it can be due to the environment, or it can be due to a mix between genetics and the environment. Now, for things like anxiety and depression, we know that it's the latter. We know that it's a mix of genetics and the environment that give rise to these problems, and it tends to be a whole series of factors that are interacting together rather than one big problem or one big issue. So families often ask me, why did this happen? Or the fact that I have depression, does that mean that that's why my son is having a problem? And that is not the case. All right, that having a family history of depression is just one factor that interacts with a whole range of other things to ultimately shape risk. Now, the last thing to say is, in terms of anxiety and depression, environmental factors actually play a bigger role than genetic factors, though again, both are important. All right, so the last clinical thing we're going to talk about before we talk about some of the basic science is we're going to talk about treatment. And we're really only going to talk about two different kinds of treatment. We're going to talk about antidepressant medications, and specifically we're going to talk about the selective serotonin reuptake inhibitors, or SSRIs, and then we're going to talk about psychotherapy. And we're mainly going to talk about one form of psychotherapy called cognitive behavioral psychotherapy. And we're going to talk about both of these treatments for depression and both of these treatments for anxiety. And much like when we compare the presentation of anxiety and depression, you'll see that there are both similarities in that we're talking about the same two groups of treatments, but also differences in terms of how anxiety and depression respond to these treatments. So let's talk about depression first. So what's the bottom line about medication efficacy, how well it works? There's reasonably strong data that fluoxetine, or Prozac, is efficacious for the treatment of pediatric major depressive disorder. And when I say pediatric, I mean from the ages roughly 8 through 18. There's also some evidence for sertraline that's not really that strong, and sertraline is Zoloft, as well as citalopram, which is Lexapro, that these medicines are also efficacious. There's very weak evidence for paroxetine, and there's virtually no evidence that any of the other many agents that families hear about are efficacious for pediatric major depression. So that's a little surprising. I mean, we hear in the media and from many doctors about many different medications that presumably work for major depression, and particularly when it comes to kids, there is not that much evidence for any of the medicines beyond the medicines that you can see on this slide right here. Moreover, there is some evidence that the magnitude of the benefit, even for adults in the antidepressants, are not as strong as many physicians thought they were maybe 10 years ago. That these medications are reasonable treatments for children and adolescents, but not wonderful, and maybe it's the same with adults. Maybe they're reasonable, but not wonderful. And there are other methodologic reasons to think why the findings are not as strong as we would like them to be. This slide shows you the most important study of pediatric major depression. It's called the TADS study, and you can see at the top of the slide where it gets its name. And this study compared the effect of medication and the psychotherapy that I mentioned, cognitive behavioral psychotherapy. And there were two main conclusions from this study. The first one was that medication, in this instance fluoxetine, one of the medicines that I mentioned on the last slide, was efficacious here for adolescent major depressive disorder. Number two, cognitive behavioral therapy, or CBT, only had a benefit when it was added to antidepressants. So what that tells us is that if you have to pick just one treatment, you're not going to use two, then the SSRI medications, in this case fluoxetine, are better than cognitive behavioral therapy. So remember I said on the last slide that maybe the SSRI medications don't work as well as we would like them to work. Well, unfortunately, they are still probably the best treatment that we have. So they work better than cognitive behavioral therapy. And that's a very different story than we'll hear about the anxiety disorders in a minute. Now, when children fail an SSRI, when they don't respond to an SSRI, there is some research in this study that you can see right here called the Tordia study. And what this study shows is for children who fail an SSRI, adding CBT can have a benefit. So again, the key idea here is that SSRIs alone are reasonable treatments, and when they don't work, adding SSRIs is a good alternative. But for both treatments, the response rates are not nearly as high as we would like them to be. So this contrasts with what we know about the anxiety disorders. And again, we're going to talk about two medications, or two treatments, SSRI medications and CBT. So this shows you a study from about 15 years ago, which was the first large study to compare an SSRI, and the treatment here is fluvoxamine. You can see the label on the figure here, against placebo. And this first study found that SSRIs were highly effective for anxiety. And we can quantify the magnitude of this effect by looking at the amount of space between the two lines that you can see on this figure. Now, we can use a number to indicate the strength of this treatment effect. And that number is something called the NNT. And if you want to know more about what the NNT is or what it refers to, that would be a good thing to raise in the question and answer period. But the bottom line of the NNT is it lets us rate how strong a treatment is, how efficacious it is. And the way we think about an NNT is the lower the number, the better the treatment. So the best treatment we could ever find would have an NNT of 1, and good treatments in medicine, treatments that are very strong, have an NNT below 5. So anything between 1 and 5 is considered a very strong treatment. So this slide shows you all the different studies that have looked at SSRIs for pediatric anxiety disorders, and you can see that the number that comes out of all these studies is an NNT of 3. So that is really a very impressive number to have. If we were to do this same thing for studies in depression, we would see that the number would be more than twice as high. In fact, it would be above 10. So the first thing to say about treating anxiety is that the SSRIs generally work well, better in anxiety than they do in depression. Now, there is a comparative efficacy study here for anxiety, and you might not be able to make it out on the upper left, but it's called the CAMS study, and this is very much like the TAD study. It compared CBT and a different SSRI. This is sertraline or Zoloft, and the findings were somewhat similar, as in this study, sertraline was also highly efficacious, much as fluoxetine was in depression. However, the findings were also different in anxiety than they were in depression because the CBT treatment also worked here. So based on these kinds of findings, generally, we think of CBT as the first-line treatment for anxiety, and we think of SSRIs as the first-line treatment for depression. And that's part of other differences that we have in terms of how we think about the treatment of depression and anxiety. So the response rate in terms of how many kids get better is higher in anxiety than depression, and the relapse rate, meaning how likely is a child to get a new episode of major depression if their current episode goes away, that's also higher in depression than it is in anxiety. So we don't do as well when it comes to treating anxiety when we do in terms of treating depression. The last thing to talk about with treatment is to just say a couple of words about the adverse effects that are associated with antidepressants. So about 10 years ago, a fair amount of controversy began to come out about how safe the SSRIs were for the treatment of children with depression and with anxiety. And this led to a number of hearings that were held by the FDA, and I was on the committees that looked at the data and evaluated the both efficacy and safety of these medications. And this led to something called a black box warning, which warned individuals about the risk of developing thoughts about suicide on SSRIs. And this slide shows you the tendency for the SSRIs to produce that effect in terms of creating a thought about suicide as a function of the age of the individual taking the medication. So at the top of this figure, with the dots that appear on the right side of that line, you can see before age 24, there is this tendency for the SSRI medications to give rise to thoughts about suicide. But after age 25, if anything, this is less likely to happen when people take antidepressants relative to when they take placebo. The last thing to say about this is, even though this is a statistical association, it is a relatively weak association. So the magnitude of the benefit from the medications, even for things like depression, where the medications don't work that well, is still greater than the overall risk. And this is why we still think of the SSRIs as the first-line treatment for major depression. However, this, as well as other side effects associated with the medication, is why for the anxiety disorders, we often think of CBT, if it's available, as the first-line treatment. All right, so what's the bottom line about treatment? Number one, the SSRIs are very effective in the treatment of pediatric anxiety. Of the SSRIs, only fluoxetine and citalopram have clearly been shown to be effective in pediatric major depression, and the effect is not as strong as it is in the anxiety disorders. And then number three, this increased risk of suicidality with the SSRIs is real, but the magnitude of the effect is small. So what that says to parents and children is they should be aware of it, and they should talk with their doctor about it, but they should not avoid taking the medication because of concern about this risk if all other signs suggest that medication is the way to go. All right, so in the last 5 minutes or so, let's talk a little bit about neuroscience and a little bit about the future and where we might go. So the important thing to know is that research on neuroscience, emotion, and applications to children are really just beginning. And there's great promise that comes from this research because through a more precise understanding of the brain, we hope to get a better handle on the causes of mental health problems and generate new ideas about treatment and new ideas about diagnosis. Now, the two main things where people are most excited is cognitive neuroscience, and I'm mostly going to talk about that, and then also genetics. And remember, at the beginning of the talk, I said that there's more excitement about novel treatments than there is about diagnosis. So the hope is that one day we're going to be able to use brain imaging and genetics to have biological tests that help tell us about risk for mental illnesses in kids and which kids are going to have more chronic conditions. Similarly, we all hope to have genetic tests. Unfortunately, right now, we're many years away, at least 5, but probably more like 10 to 20 years away from having those kinds of indicators. There's more hope about developing novel treatment, and in general, neuroscience has been more helpful in generating novel treatment than it has been in terms of helping in establish new diagnoses. So let's just say a word about brain imaging and diagnosis. So this shows you a slide that uses a technology called functional MRI. And functional MRI, or fMRI, takes advantage of the fact that the magnetic properties of the blood in our body changes when the amount of hemoglobin changes in our blood, and that gives the brain its own natural brightening signal that you can see illustrated right here when activity in a brain region increases. The real beauty here is that this is an entirely non-invasive technique that is very easy to use, and the kinds of studies that we have been conducting uses paradigms like the one shown here, where a child might lie in an MRI scanner and look at different kinds of movies, and there's been particular interest in examining the response of the brain to a fearful face, such as the one that you can see on the left there, when it's contrasted with a neutral face. And there's a certain part of the brain that you can see illustrated here in these two white boxes, and this is a slide that cuts through kind of a cross-section through the brain. It's as if you were looking right at a person who was looking right at you, and kind of right behind the eyes, you can see those two lit-up regions, which are the amygdala, which is part of the brain that's involved in detecting things that are salient, like threats and rewards. And the idea is certain kinds of stimuli, such as certain kinds of faces, lead to a greater response in the amygdala in people who are anxious or depressed. Now, the magnitude of this difference isn't large enough for this to be used in terms of diagnosis, but it has been helpful in terms of thinking about novel treatments. So what this picture shows you right here is the circuitry that's engaged when individuals attend to dangerous stimuli. So you can see the guy in the upper right-hand corner of this picture is walking through the woods, and you can see that he comes across a snake. And what happens in situations such as that one is that this part of the brain, the amygdala that you can see illustrated right here behind the eyes, is incredibly rapidly engaged. And we know this from brain imaging, that when we take pictures of the brain, when people look at pictures of faces that feel afraid or things like snakes, the speed with which the amygdala becomes engaged is incredibly rapid, more rapid than we can even consciously process. And what that tells us is that when we think about treatment, we also need to think about treatments that require rapid action on the part of a child. So the kind of treatments that my group has been working with are variants of video games that you could see right here, and this shows you one of these video games. It's a form of attention retraining where kids play this video game and it changes their attention, and we've had some pretty good luck helping anxiety. Now, the internet community has gotten quite excited about this, and people are already selling video games like this, and it's not that different from things like luminosity that you see advertised frequently. The important thing to note is that all of these things, including luminosity and including this research, they remain only research tools, and these are not the kind of things that people should be spending money on yet. And in fact, there is some concern that if these video game therapies are not used appropriately, they could actually be harmful. That said, they are very promising techniques, and I do think therapies like this will actually be helpful one day not too far off, and probably long before we have things like brain imaging tests for diagnoses. And I have a metaphor that I use with the patients that I talk to that describes using these kinds of treatments as very much like learning how to hit a baseball or driving a car. And this is a picture of Ted Williams, where Ted Williams taught his hitters that there were two parts to hitting. You have to learn the strike zone, and so that's something that we learn kind of slowly and carefully, and this is illustrated here. But you also needed to learn how to hit a pitch that was thrown very fast. And when you were trying to do that, you really should not be thinking about the strike zone. You should be practicing swinging a bat over and over and over. So the video games for kids with anxiety are a little bit like practicing swinging the bat. These teach kids to change their attention in very rapid ways. So the last thing to talk about is something called fear conditioning. And fear conditioning is the kind of experience that you learned about in graduate school, where a neutral stimulus like the sound that you can see in the cage with this rat as he jumps is paired with an aversive stimulus like the shock, and the rat learns how to become afraid of that sound. Well, there's a great amount of excitement about fear conditioning, because when we look at the brain regions that are engaged by this process in people, in monkeys, and in rodents, they're tremendously similar. And that's very exciting for us as neuroscientists, because when things are similar in rodents, non-human primates, and people, the things that we learn through basic research are much more likely to apply to people. And so this has been a very exciting area, again, much like the attention retraining, in that people have discovered complex biochemical pathways that you can see illustrated here, and that people have used these pathways to come up with novel medications that are also quite exciting. Again, I think that most of this work is more relevant for adults than it is for kids, but even here, we're still years away from having these insights be useful for individual patients. On the other hand, there is much more excitement about this, about us getting closer to having novel treatments relative to having things like genetic tests or brain imaging tests. All right, so we fairly rapidly moved through a very large amount of material. I spent most of the time talking about clinical research, where I talked about presentation, longitudinal course, familial aggregation and treatment, and then we ended up by talking about how we might come up with better diagnostic markers or genetic tests, the kinds of things that we think are many, many years off, again, much more than 5, maybe as long as 20 years off. And then we also talked about a couple of novel treatments, and I only talked about 2. There are really many more, and it's created a really exciting time. So before we move on to questions, I do want to put up, I thought I had a slide with my, there it is. I do want to put up my phone number to refer patients and my email address. If you have a question about a patient, it's best to use the phone number there since that's a private line. The email and the number below is not a private number, so it's best not to use that one. And then I would also like to thank everybody for their attention, and I would like to thank the ADAA, both for sponsoring this particular webinar, but also for the tremendous amount of research that they have done over the years to really call attention to the issue of anxiety disorders, both in children and in adults. So maybe with that, do we have time for a question or two?
Yes, thank you so much, Dr. Pine. Fascinating, fascinating presentation. And I want to let everybody know, somebody asked if the PowerPoint slides will be available. They will not. However, the whole presentation will be available to view on the ADAA website very soon, maybe within a week or so. So you'll be able to watch it again, and you can even pause it and take more notes.